Good morning and welcome to QI PowerHour. It's Deborah Wright here at the Health Quality Council. As most of you may know, QI PowerHour is a free monthly WebEx offering hosted by the Health Quality Council here in Saskatchewan. It provides an opportunity for colleagues across healthcare as well as other industries to hear from local and national improvement experts on a variety of quality improvement related topics. Just a reminder that following today's session, a recording of the event will be posted to our Health Quality Council website for you to share out with colleagues who were unable to join us in person today. We also invite you to check out our recordings and presentations from past sessions on demand at the address listed on your screen. While you're on our Health Quality Council website, I'd also invite you to sign up to our distribution list to ensure that you receive regular invites for all our upcoming QI PowerHour sessions. Now, over the last number of months, QI PowerHour has continued to see a spread throughout our province within our provincial healthcare system, as well as to those in other organizations across Saskatchewan who have an interest in quality improvement. We've also begun to see a spread to other organizations within Canada and even abroad. So with that, again, I want to welcome everyone to QI PowerHour. We encourage folks to share their questions and insights during today's session by making use of the chat function. You'll find the chat function on the right-hand side of your screen. You can access the chat function by clicking on the message bubble on the top right-hand side of your screen. And we encourage you to share your questions, comments, and ideas throughout the presentation. We will have some time dedicated to questions and Q&As at the end of today's presentation. Please send your questions to all participants so we can all join in the discussion. So I just want to take a moment to ask you to practice using this function by typing in the chat the name of the organization you're joining us from today. All right, we're starting to see some folks type in where they're from. Good to see. But a few more folks.
So some of these are actually coming through just to the host and presenters, so we'll read them out. Sask Health Authority, the Ministry of Social Services, Sherbrooke here in Saskatoon, Manitoba Health, Community Safety and Wellbeing, Moose Jaw, Prince Albert. Thanks, everyone.
Awesome. Okay. So finally, we also invite you to log into your Twitter account and tweet out during the session to share your learnings. You can use the hashtag QI PowerHour and the handle HQCSask. For today's session, we'll also invite you to actively participate using chat and the Twitter. Okay. So I'm delighted now this morning to welcome Sarah Collins to her session on Hub Tables in Saskatchewan. Sarah began her work assisting others to strengthen collaborative relationships with the Dispute Resolution Office with the Government of Saskatchewan in 2009. She has had success in transforming the way people work together through mediation, facilitation, and coaching. Sarah is passionate about working with organizations in the areas of leadership, conflict resolution, change management, and business improvement. In her current role with the Integrated Justice Services, Sarah is responsible for supporting community safety and well-being through collaboration, information sharing, and shared measurement. With this time, I'll welcome Sarah to begin her presentation.
Good morning, everybody. Thank you so much for having me. I'm absolutely thrilled to be here. I have been a long-time participant of PowerHours, and so I feel really, really excited that I get the opportunity today, so thank you again for that. I also wanted, one of the other pieces I was thinking about this morning on my drive-in was that I have this privilege that is, I think, a rare privilege that I get to talk about a lot of the amazing work that other people are doing. So I'm thrilled to be able to talk to you about Hub Tables today. I am thrilled to be able to talk about lots of the exciting work going on in communities, and just want to highlight that this work is not being done by me or by our branch. It's being done really at the community level, and the amazing folks who are working on the front line to change people's lives is just a really exciting thing to be a part of. So with that being said, wanted to start off today with just a little bit of context for everybody. If you have questions, we'll absolutely get to them, and so please feel free to ask anything, and anything that I can't answer for you today, I will absolutely get back to you on. So just wanted to give you that information as well. One of the things that we think about here at Community Safety and Wellbeing, and this is a conversation that's also going on a national level, is that typically when we talk about this idea of safe communities or increasing people's well-being across our country and in our province, we have a tendency to think about our incident response. So we think about when we go to communities and they're worried about what's going on in terms of the safety of their citizens, we at the Ministry of Justice typically get a response that includes something to the effect of, we just need some more police officers and everything will go fine from there. I'm sure folks, our colleagues across the health sector know that the other response we get is that we just need more doctors in our emergency room, we just need more paramedics, we just need more of whatever the emergency kind of incident response type approach is. And so when we're thinking about community safety and well-being, we are thinking about it kind of in a more broad approach. And what we're thinking about, and Hub Tables definitely fit into this conversation, we think about the next kind of piece of the puzzle, not just being incident response, which is important, but also including some risk intervention. So how do we support folks when we can see that the current path that they're on is going to lead them to requiring some incident response services at some point in time? And Hub Tables are one example of this work, and we'll talk more specifically about them. We also think about reducing risk and prevention and how that fits into this conversation about community safety and well-being. Ultimately, we know that by the time people get to justice, it's too late, and really that there was lots of signs along the way or things that we could have intervened to prevent long before they ever end up on our doorstep. I wanted to highlight that ultimately I think lots of our colleagues in healthcare have been here for a longer period of time. I think folks in the health sector have been thinking about this kind of proactive versus reactive approach for longer than other human service partners have, and so it's exciting to me that we're all starting to think about it in the same way. The last kind of ring of the circle, of course, is really about social development and kind of promoting and maintaining community safety and well-being. And so the slide is a little bit wonky right now, so I apologize for that, but ultimately we want to think about information sharing, collaboration, and measuring success. And in order to actually accomplish this shift from incident response to a more proactive approach, we really need to be able to think about what our relationship looks like between government and communities. We need to think about what our relationship within the human services and governments look like. We need to be able to agree on how we can measure things together and evaluate them. And we ultimately need to share information. So just wanted to give folks a bit of context as we start our morning together. So what is a hub table? At the hub table, we think about this idea of a team of designated staff. They come together and they literally sit around a table. So often in communities, we'll have folks from a variety of different agencies come to a table. They're looking in their community, or we like to use the term, they've got eyes on folks in the community to say who might be experiencing some elevated risk and how can we intervene before ultimately the police are getting involved, they end up in our emergency room, other options like that. So the idea is that these folks get together, they coordinate a response, and they mobilize existing resources. So this isn't about ongoing case management necessarily. It's really about how do we use the resources that are already available to our community, and most of our citizens are able to connect with those resources. We're looking for folks who might be falling through the cracks or being missed. And so wanted to give you that kind of definition and context. Community agencies often include mental health clinicians, they include police, they include probation services. We have a huge number of referrals that come from our partners in education. So often, especially when it comes to our youth referrals, we think about teachers and educators really having an understanding of what might be different for Johnny or for Jessica. We have strong partnerships with social services. Other service providers can sometimes include, there's a hub table in Saskatchewan that has an emergency physician that sits at their steering committee level, and there is a, often like so in North Battleford, for example, one of the partners at the table is Battleford Treaty 6 Health, or Battle River Treaty 6 Healthcare, and so we work with agencies that make sense for each community, and so I think that's a really important part of this. I mentioned a steering committee, so I want to give you a little bit more context about that as well. Every hub table is made up of frontline folks, so people in each of these organizations who work on the front line. They have the ability to respond and perform some sort of intervention. Every hub table across Saskatchewan also has a steering committee associated with it. So the steering committee is made up of leaders in the same organizations that have the ability to either flex mandates slightly. They have the ability to respond to systemic problems that the hub table is noticing. Often in our community, we are able to connect people to the right resources. Sometimes there's more systemic, kind of bigger picture problems at play. So the idea behind the steering committee is that they have this ability to intervene at a higher level and solve some of those systemic problems. I want to tell you a little bit about Jessica. Jessica is, so when I think about Jessica, the hub tables across Saskatchewan have served more than 5,000 clients in the period that they've existed. Jessica is just one example of these clients. So I think about 5,000 Jessicas or Johnnies existing across our province when I think about the work being done at hub tables. So what we know about Jessica is that the police actually responded to one of Jessica's, a call for service from one of Jessica's neighbors. And what Jessica's neighbor identified is that they had seen this young person outside of her 4-story balcony railing. And so when the police arrived on the scene, they did a check at Jessica's mom's house. Jessica was no longer on the balcony. They knocked on her apartment door, and when Jessica's mom answered the door, the police were invited in. They came in to check on Jessica. Jessica, as they were speaking to her, she talked about, she really didn't think about how dangerous it was being on the other side of the balcony. She committed that she wouldn't be doing it again. She committed to safety, that she wasn't going to be hanging over the balcony. Jessica's mom told the police that she was horrified that Jessica was outside the railing, and she committed to following up with Jessica about the danger. The other piece of information that the police know is that the police were also aware of Jessica had recently been picked up for shoplifting twice in the last year or so. She also very recently, within the last number of months, had been questioned at a party that the police had responded to. Previous to this, Jessica had had no contact with the police. And so the police find themselves in this situation where they're not arresting anybody as a result of what's going on for Jessica at this point in time, but there is this dynamic where there's something going on here that we can't quite put our finger on. And one of the reasons we can't quite put our finger on it is that ultimately there's other people potentially involved in Jessica's life. So the police officer made a referral to the local hub table. They were concerned. They highlighted Jessica's new kind of criminal activity, so her shoplifting and this potential kind of party conversation that they broke out. They also talked a little bit about they weren't 100% convinced that Jessica wasn't thinking about suicide while she was on the other side of the railing. And so they refer her to her local hub table, and then the magic happens. So we start to think about what else is going on in Jessica's life. So we'll talk more about how the process actually works in just a minute, but what you need to know is that once Jessica is referred to the hub table, the police talk about the risk factors in her life and what's going on, and then what happens is around the table, other folks get to start sticking up their hands saying that, hey, we know Jessica and we're involved with her, and we would really, really like to be able to offer some information to support Jessica. So what we find out from Jessica's school is that up until last year, Jessica was a really, really good student. She struggled sometimes in math, but really loved biology and chemistry class. This year has been a bit different for Jessica. She's only been attending school about 50% of the time, and when she is there, she's often falling asleep in class. The school has made several calls home to Jessica's mom. Jessica's mom's committed that things are going to improve in terms of her attendance, but they have not over the last 6 months. Jessica's also been seeing a counselor at school sporadically. What Mental Health and Addictions knows is that Jessica was actually referred to Mental Health and Addictions 8 months ago after a trip to the emergency room as a result of an overdose. Jessica was very engaged with her counselor. She showed up for all of her appointments and worked through some programming around responsible alcohol use. Jessica's mom was at all of the appointments with Jessica, and she finished up her last appointment about 6 weeks ago. Her file had been closed with Mental Health and Addictions at that point in time. What the hospital knows, or the emergency room knows, the medical information we know, is that Jessica's actually been admitted to the ER 3 times in the last 8 months, all as a result of overdoses. She was referred to Mental Health and Addictions. Jessica's mom has been at every ER visit with her. She told staff that she had been taking Jessica to her regular mental health appointments, and Jessica has indicated that all of the overdoses that she's had and all of the emergency visits she's had have been as a result of accidents. So what probations knows? So Community Corrections has been in contact with Jessica as a result of her shoplifting matters. So she has a youth probations worker, someone that's working with her. But the other thing that Community Corrections knows, and they know this as a result of some of the information they have, is that mom's partner was recently released from custody. Previous to his release, there had been some concerns about domestic violence. He was actually in custody on an unrelated matter, but about 12 months ago he was released, and they have that information available to them. So what happens for Jessica? Well, what happens is that all of these folks now know a little bit more information about Jessica, and no one was doing bad work in the silos that we currently operate in. What we know is that most of the time when people are falling through the cracks is that it's as a result of the challenges we have communicating with each other. And to be perfectly candid, when I started my work with the government of Saskatchewan, I remember we don't not share information because we're trying to keep things from each other. We're not trying to keep secrets. We're not trying to hurt citizens and people that live in our community. I do remember starting my job and being told really kind of point blank that if I shared information about people, that was probably the biggest kind of ticket to unemployment I could find myself getting a hold of. And so what I think about is that we've trained ourselves, and privacy is important, and it's not about one or the other. It's really about when do we need to share information to help support people who are at risk of harm coming to them, and when are we keeping information that's really private, and who needs to know what when, and how does all of that work. And so we'll talk a little bit more about that, but I just wanted to flag that for folks. So what happens to Jessica is that as this conversation is happening around the hub table, they decide to go out and connect with Jessica. They perform a bit of we call it a door knock at the hub tables, but they go out and connect with Jessica. And what they find out is that Jessica has a bit of a secret. And Jessica's secret is that mom's partner has been physically assaulting her for a number of months since he's been out of the institution. He's in breach of a bit of his order because he's seeing mom when he shouldn't be seeing her. And one of the things that we think about is that, so Jessica is this community member who's had contact with our hospitals, she's had contact with our mental health and addictions people, Jessica has had contact with her probation folks, Jessica has had contact with the police. She's connected to some services. But one of the dynamics that we know is that Jessica's mom has told her that if she tells anybody about the domestic violence going on, that Jessica won't be able to stay in mom's care, that there's a really good chance that Jessica will end up in foster home and in a foster home or outside of the care of mom. And so Jessica has been carrying this weight with her for the last year that mom's in trouble, I don't know how to help mom, and in addition, if I do say anything to anybody, what's going to happen is that I'm going to end up not with my mom. And then I'm not only worried about myself, but I'm also worried about mom at that point in time. What happens if I'm not around? So as these folks converge from the hub table around Jessica's door and start to have this conversation, the first thing they're sharing with folks is that they're not here to get anybody in trouble. They're here really to offer support, and that they're worried about Jessica and her mom. And so what happens is that on this door knock, the hub table representatives are able to come up with a bit of a plan to ensure mom's safety and Jessica's safety going forward. And I think about all the people who have touched Jessica throughout the system, and we would never know what was really going on for Jessica if we didn't have this ability to share information. So a little bit of context, and again, a reminder that there's, you know, for every Jessica, there's a Johnny, there's a Sally, this story is not an uncommon one in our province, and we know that lots of people can connect to services quite regularly and through kind of our standard channels. This is really about assisting people when they're in that elevated risk stage, and we're worried that they're going to fall through the cracks. What you need to know about Saskatchewan is that we have 14 hub tables serving 15 communities in the province. We also currently have 2 intervention circles serving 2 First Nations. Very similar kind of philosophy in terms of finding risk in the community and getting that those people experiencing that risk connected to services in terms of hub tables versus intervention circles. What we know, what our 2 intervention circles are working with right now is that they also continue on with a case management program afterwards. So typically at a hub table, once the door knock has happened, Jessica's been connected to services, the hub table kind of lets go of Jessica because her risk has been reduced. In our First Nation communities that are currently working through these intervention circle models, they're holding on to Jessica and doing a bit of a check-in with her and some case management on an ongoing basis. And part of that is because of kind of the approach needed in the community. Part of that is about size, and so Ochapowace First Nation has seen some really incredible results, so has Muscatay. We'll talk a little bit more about some of the really exciting things happening at both intervention tables and hub tables in the communities across our province. When we think about risk factors and we're looking for risk in our community, we're thinking about a variety of things. I work for the Ministry of Justice. Most of the time when people are talking to me, they assume that I'm thinking about criminal activity and I'm thinking about how police are going to be responding. What we know is that most of the folks that we see, criminality is actually very low on the list of things that potentially are a risk factor for people. In fact, in 2017-18, when we think about all of the discussions that occurred across the province, the most prevalent risk factor was mental health. When we couple mental health and addictions, of course, that even goes up further because alcohol was the next highest risk factor. Antisocial kind of negative behavior, so not quite on the kind of crossing the line of criminal involvement. And then criminal involvement was number 6 in terms of risk factors and what was going on. Of course, these numbers add up to more than 100% because what we know about folks is that often they'll be experiencing more than one risk factor. So in order for the risk to be elevated, maybe there's concerns about mental health as well as concerns about missing school. When we talk about mental health, because I know I have some health colleagues on the line, one of the things that we think about is that this is not only diagnosed mental health, it might be kind of self-stated, so I'm indicating I have some concerns about my mental health, or it could be kind of assumed or predicted mental health concerns. So we're covering the gamut with that 57%. When we think about risk generally, one of the biggest pieces and the biggest learnings for hub tables, I think, across the province is that when we think about what the perceptions of our current risk are, we don't often factor that into our analysis of what's going on. And this, of course, ties to systems thinking, which many of you would be familiar with. So when we think about systems thinking, we think about this holistic approach to analysis. It's thinking about how systems work over time and in context of larger systems, not just kind of the straightforward breaking them down into separate elements kind of approach to things. So one of the things that we've noticed and that we've learned across this journey is that often one of the reasons we don't see our current level of risk is because we have a bit of a short-term focus or a narrow focus. So people who are focused on the short term, we can be blind to kind of the most catastrophic risks coming down the line. We're blind to some of the benefits of preventative action. maybe folks are looking for a quick win. Maybe our systems are set up to design us to focus kind of on the short term or narrow, but ultimately we're distracted by the fire in front of us and we're missing the smoke everywhere else. The other thing that we think about is this kind of idea of the normalization of deviance, or I think about the frog in boiling water. So we often just accept the unusual as normal in our current systems. We are exposed to people who experience such a wide variety of risk factors on a daily basis that it can be really challenging to see what's going on, you know, in terms of is this risk as a human being increasing? Often we think about, you know, it kind of worked out fine last time, and there's just nothing that we can do about that. It's just the way that it is. And that ties into complacency when we think about our current risk. So it's this kind of belief that either the really bad thing is going to happen elsewhere or you just can't control it. I think that as human services, we, because of the work that we see on a regular basis, it's just kind of an expectation that people will experience this kind of risk in our community. The fourth category that we think about, or the fourth thing we want you to keep in mind, is this idea around silos, and this has been absolutely critical and huge at Hub Tables. So teams tend to focus on what their specific scope is. The narrow focus keeps us kind of blind to the ripple effect of our decisions. It's tough to kind of assume responsibility for a whole human being when we're only responsible for one part of their well-being. And so thinking with this in mind, we think about, yes, there's risks to sharing information, absolutely, and we've done a lot of work in our province to think about what that looks like ongoing and done some changes to a lot of, you know, legislation and other pieces. But when we think about what's going on and the risk of information sharing, we don't often think about what's behind us. So how we perceive where we currently are is a big factor in the success around Hub Tables. So having folks stop and think about that. So yes, we're sharing information about Jessica. Yes, we absolutely have the legislative authority to do that. It can feel like it's a big risk to think about information sharing. We know that if we don't intervene with Jessica, things are only going to get worse for her, and so thinking about kind of this dinosaur behind us as we think about crossing this gap to information sharing. So when we think about process around Hub, when we're thinking about the 4 filters, I imagine it as this ramp to kind of cross the divide into information sharing. One of the things that you might be interested to know is that in June of 2016, there was regulation amendments to all of our information and privacy work across the province, and including the Freedom of Information and Privacy Act, the local version of that, HIPAA, of course, the Health and Information Privacy Act, as well as the Youth Drug Detox Stabilization Act. So the work that has been done to support information sharing ongoing. These regulation amendments were not just specific to hubs, they were really to all integrated service programming. And the idea is that when you have an information sharing agreement and when you're doing it for the right purposes according to the regulations, you're absolutely able to share this information. And it's been critical in assisting people across our communities here in Saskatchewan. So a little bit more detail on what the 4 filters look like and how this kind of fits into things. I probably haven't mentioned 4 filters yet, but what I think about is that it's this ramp that gets us to information sharing. So how do we build a process that helps everybody understand what they need to know and at the same time is really respectful of the need to keep certain things private? I think about a family physician at some point in time being a great example of this. There's going to be a whole bunch of information that a family physician knows about me. If they're trying to make a referral to a hub table for me because they're worried that I might be the victim of some domestic violence, they might be sharing some information about me and my risk factors, but they're ultimately not going to also be sharing with the hub table a bunch of my other health information. Filter 1 is really done at all of our home agencies. So in the Ministry of Justice, Social Services, you know, in mental health clinics across this province, we figured out that, you know what, we're worried about risk in this person. Their traditional options have been attempted, so this isn't, hub tables are not meant to be a dumping ground for our hardest to serve clients. We've really tried our best on our end. The risk factors cross multiple kind of agency, you know, silos, right? There's a likelihood that one person intervening is not going to be able to solve this problem for this particular individual or family. There's also the probability of harm occurring. And so once we've done this kind of filter, we've filtered people through this first filter, we get to the point where we can start to make the referral to the hub table. And so what happens next is the second filter that we talk about. So we bring people to a hub table. We're bringing them just with their present known risk factors. So in Jessica's case, when the police bring her to the table, they might highlight that her recent uptake in criminal activity is something that they believe is a risk factor. They might talk about her potential risk of suicide or the concerns from people around Jessica about that potentially looking like that. Maybe if they got a bad sense from mom, or they believe that mom was maybe not interested in supporting Jessica, which wasn't the case in this example, but maybe that's going on, they might also bring that as a risk factor as well. So they're not using Jessica's name, they're not using any of her identifying information, so they won't even talk about how old Jessica is. They're talking about a youth with the following risk factors, and they'll say, we're worried about the youth's kind of potential for suicide, we're worried about the youth you know, parenting for the youth, we're worried about the youth's recent criminal activity. And so then once there's consensus around the table that this is, yes, elevated risk and we need to potentially intervene, we need to be able to share information at this point in time, we move to filter 3. And so what happens at filter 3 is that we have a conversation about Jessica's name. So the group who brought Jessica to the table starts to identify her name. Maybe they provide more information about her location, those kinds of pieces. And we don't talk specifically about what's going on at this point in time. We put up our hands and we say, you know, yes, we need to be involved. We've had some contact with this person before. Let's move into a filter 4 conversation, or this shift to talking about how we can wrap around this particular person. How can we do this multi-sector planning? How do we get to a home visit or an offer of service? What does this kind of door knock potentially look like? The fourth filter also includes looping back, of course, to confirm that the risk has been reduced. So there's sometimes a little bit of conversation saying, you know what, Jessica was reconnected to the mental health clinic, and yep, she attended her first meeting, so we can now say that the risk has been elevated for Jessica. What you need to know about some of the information we have. So in 2017 and 2018, about 62% of door knocks, or people that we knocked on the door of, were connected to services. So they were you know, reconnected or connected to different services in their community. About 27% of the folks that we served were informed of services. They didn't make a commitment or get connected immediately, but they were able to get more information about potential services that were out there for them. Only 5% of our clients refused service, so said, please get off my doorstep. We're not interested in anything that you have to say. And because of the vulnerable population that we're often serving, we also know there's a significant amount of kind of relocation or unable to locate clients. So unable to locate is less than relocating, and one of the things that you might be interested in is that when folks relocate, if they move to a community, another community with a hub table, there's a way that folks have developed an opportunity to share information across their own silos to be able to ensure that those people don't get dropped when they're moving from, you know, Saskatoon to Regina. And so there's been some incredible work done at hub tables around that as well. If you had to think about hub from a logic model perspective, the ultimate outcome we're really trying to achieve is about reducing risk and improving community safety and well-being. When we think about kind of output, so we really get this cross-agency awareness. We get an awareness about our responsibility to act, and we ultimately get the mobilization of resources. And so what it really is that you don't know what you don't know, and so having a conversation really helps with ultimately achieving our ultimate outcome. There's been some evaluation work done around hub tables. There's actually been a number of evaluations done around either specific tables or kind of the whole province's approach to hub tables and what that looks like. Much like you all have experienced, is that one of the pieces we find challenging is how do you really quantitatively measure what a prevention of harm occurring looks like. And so hub tables are currently, when we think about evolution, that's one of the things that they're currently working on. So in addition to all of the qualitative findings that have been had over the last number of years, hub tables have been developed. Tables are really working towards how do we develop more quantitative measures and evaluate ourselves based on that. What could we talk about in terms of a return on investment? As we imagine there is a significant cost in a community for 10 or 12 people to be sitting around a table for a couple of hours a week and then participating in door knocks. And when I think about the emergency services that might be needed for Jessica and her family going forward, I think that, we all kind of in our mind know that there's likely a return on investment there. Ultimately, we need to be able to quantify that at some point in time. And so that's one of the places where hub tables are evolving to at this point in time. We think about the future for Saskatchewan and what this means. So hub tables have evolved outside of Saskatchewan. Of course, they were started in Scotland, and our province spent some time in Scotland, and we like to talk about leapfrogging. So we learned some really cool things from Scotland, brought them back to Saskatchewan, and now kind of evolved our tables to be, we would say, I think, like in appropriate level of competitive manner, that we were able to leapfrog them and make them a little bit better. We've also shared this information with other provinces and other folks across North America, and so we know that there's been kind of evolving dynamics and evolving approaches done across North America. And so when we think about the future of Saskatchewan and where hub tables might be going in the next little bit, we really want you, and we think about integrated service maturity. So this idea that ultimately when we first started thinking about hub tables, one of the reasons it was so important, and this goes for all kind of case management, integrated case management work, is that when we're working in our silos, we don't have contact with what's going on outside of us. And then we kind of shift, and as we cooperate and coordinate between service providers, one of the things that happens is that then what we don't want to happen is for the hub table to become its own silo, or for other kind of risk intervention groups or case management groups to become their own silo. And then we eventually move to true kind of collaboration amongst service providers. So how are we all working together? We're planning together. We're measuring together. We're really working as one unit. And then ultimately, I hope for the citizens of Saskatchewan and for people, kind of the next evolution of all this work will be that really service providers converge to achieve client outcomes. So it doesn't matter, it's this whole idea that we've been talking about for a long time around, there's not a wrong door, we're going to bring the services that you need to you and respond in that way. We're also very interested in how we might kind of reach out to other people in our communities, whether it's other service providers or potentially citizens, to highlight risk in our communities. Now, there's of course a little bit of risk associated with this because we don't want, neighbor disputes becoming hub referrals. But one of the things that when I talk about hub tables across the province, one of the things that I hear from folks is that, so the first thing I hear is, you mean you were not already doing this, which is a typical response, and then, hey, I know somebody who really could benefit from a hub referral. In fact, I can't remember a conversation I've had about hubs in communities where I didn't hear that from people. So we ultimately, as citizens and as other service providers, know what should be referred potentially to a hub table. So where the evolution of this is now around this idea of how do we get kind of those folks engaged in hub tables. And what will that potentially look like going forward? And so that's one of the other conversations going on. We even think of, the other piece we're thinking about is moving even further upstream. So as hub tables have evolved in the province of Saskatchewan since 2011, when the first one started in Prince Albert, one of the things that we've been thinking about is, so the first kind of wave of people who were referred to hubs were really chronic users of service. And so we have people who have been chronically homeless for a period of time. We have people who have been chronic, had chronic addiction issues for a really long time. And it's important to be able to bring those people to the table and to have a conversation about that. As those kind of glaring opportunities presented themselves, tables are now shifting towards kind of this, how do we get involved just a little bit sooner? So when we find out that a teenager is couch surfing, instead of waiting until they've been homeless for a period of time to intervene, how do we get somebody to have their eyes on that youth so that we know that they're couch surfing, so that we can offer some services earlier rather than later? And this, of course, would be work that all of you are very familiar with as health professionals, because I often use the example even just around, so yes, we need to intervene before somebody has a quadruple bypass, but doing it when they need, when they need a triple bypass is not really moving further upstream. We want to be thinking about prevention in a variety of different ways, thinking about prevention in terms of medication, and then ultimately backing that up to the point where we're really intervening early and we're talking about prevention in the truest sense of the form, which is how do you get to the place where even if you have some family history, how can we reduce your risk long term for ever needing this kind of operation? So that's really what I have to talk about. I'm really excited for the opportunity if anyone has questions or you're curious about anything. That's kind of my part of the information. I want to, thank everyone again for having us, and I'm curious if there's things that folks are thinking about or if you have questions about things.
All right, wonderful, Sarah. Thank you so much. That was a really excellent presentation. We're sitting and listening quietly and feeling thankful that this has been recorded, because I think this will be a resource that many of us on the call, if not others, will want to listen to and think more deeply about. But we have some questions that have come forward through our chat, and I'm just going to highlight them as I see them. So the first one, the question of, on the topic of integrated service maturity, have you developed a tool for helping Hub Table teams evaluate their local effectiveness or teamness and identify next steps for how they can continue to grow together?
Yeah, so it's something that we kind of have a maturity model for our integrated services that we've built. We're working on kind of developing that just a little bit further around a rubric. The other thing that folks might be familiar with is that Dr. Chad Nielsen, who was previously with the University of Saskatchewan and now works with, I think it's called Living Skies Inquiry, his own consulting firm. He has also been working on a Hub Fidelity model, and so it's interesting. There's a couple of different tools out there. It's definitely something, as we develop it, we'd be absolutely happy to share. Right now we have a bit of a kind of a matrix, but what we'd really like to get to the point is that where folks can ask kind of specific rubric, I think about kind of our education colleagues around the table driving some of this conversation to say, how do I really know where I'm at, and what is all of the underlying pieces that get built into that?
Great, thank you, Sarah. We have another question as well, and this is from Nancy Hughes-Gibb. How do you build trust with your First Nations partners?
So part of what we think about is that ultimately lots of it is driven from a community level. So I don't want to take any credit for communities like North Battleford, like La Ronge, for example, who really have done incredible work to ensure that they're able at a community level to get their First Nation partners to be at the table and supported. And so I think it's done on a relationship to relationship kind of path. I think that we have had a tendency to be a little bit prescriptive and paternalistic when we worked with our First Nations partners previously, and what we know doesn't work is showing up saying, this is the best thing since sliced bread, and hurry up and get on board. And so thinking about driving those relationships from a community level is the first thought I have, and then just ensuring that we're not being prescriptive and paternalistic in terms of approaches that we're taking.
Great. So it looks like we have another question. We're curious to know if you have someone from primary care or public health involved in your harm reduction work with the Hub.
So my understanding is that we do not have anybody from primary care or public health. One of the things that we've been talking about is what makes sense in terms of expanding tables. And so there's been a recent push, the Saskatchewan Housing Authority, for example, has started to work with hub tables across the province to say, how do we get involved and how can we be involved? I think there's absolutely an opportunity to grow the tables. When I talked about leapfrogging, so in Chelsea, Massachusetts, which is a small in size but large in population community just outside of Boston, they have about 30 regular participants at their hub table. So they include community service providers, they include a variety of health folks, they include police, and the only rule that they have is that there's no political hacks allowed at the table, which I appreciated their frame on that. And so the idea is that as you expand the table, ultimately the weight comes off of some of our typical service response providers. I think this idea around primary care or public health being involved around the harm reduction piece is going to be, would be a really exciting place to go. So if there's anybody who's interested, feel free to contact us and we will connect you with your, with the local table, or we can figure out how best to get folks connected at those tables.
Great, thanks, Sarah. Sorry, we're just coming off mute there. Certainly agree, great opportunity to kind of continue to build the table. The table will become very big, but I think it's great. We have another question with respect to evaluation. So the question is coming in terms of who is working on the evaluation and who is leading the work, and is there a coordinated provincial evaluation strategy?
So some of the, when it comes to, because there's kind of two pieces to this. So there's been some previous evaluation work. Dr. Chad Nielsen, there's been some evaluation work done by Norm Taylor, who some of you might be familiar with. When it comes to shifting away from just the qualitative to the quantitative, that's something that we're thinking about here within Integrated Justice Services. What does that look like? And not necessarily in just a formal way. I think we'll have to get to that at some point in time. But ultimately, what we know is that for our tables, and I'm sure you guys experience this in some of your work too, so our tables are out there doing the good work that they need to be doing, and our steering committee members know the value of this kind of evaluation or pulling some of that quantitative data and results into the conversation. The time that they have to do that is really a challenge for them, and so one of the things that we've committed to is that if there's some tables who have a little bit more capacity for whatever reason to go about that, how do we start with them and then eventually roll that out to kind of a bigger provincial picture? And so if there's an opportunity to, you know, have some sort of conversation around what does return on investment look like for a hub table in one community, how do we pull that kind of out into a bigger picture? So I don't have like a beautiful plan at this point in time, but here at Community Safety and Wellbeing, we're thinking about that not just at hub tables, but across integrated service across our province.
Wonderful. Thanks, Sarah. The next question we have is, do you scale up the single case approach to the system level? I think folks are looking to better understand how best to break silos in an ongoing way.
Yeah, so different tables have taken a different approach to this kind of piece. So something I didn't talk about today was in Prince Albert, Community Mobilization Prince Albert has, not only do they have a hub table that they support, but they also have what's called a Center of Responsibility. And so for a period of time, they have had folks seconded from a number of different human service ministries and policing services and things like that to work just on systemic issues and what some of the possibilities are. I will give, their website is wonderful. They have some of the information about the Center of Responsibility and what they've been working on. There is some good work done about, some really excellent work being done through their core, and other tables have taken a slightly different approach to it. So in Saskatoon, for example, they flag issues as more of kind of like a systemic approach. And what they do, they flag issues as systemic, and then they bring that to their steering steering committee, and then their steering committee is well supported. So they have really excellent members who sit at their table who work towards solving these systemic problems. And for example, they recently, at a meeting, the Chief of Police in Saskatoon, Chief Troy Cooper, is in attendance saying, okay, how can we work on and solve this problem? They've been doing really excellent work in terms of how do they bring this to a kind of leadership level conversation.
Great, thanks, Sarah. I'm just going to pause to see if there are any other questions that folks may have. I think we've covered what I've seen in the chat, but I do want to give a moment before we move to wrapping up the call. Also, to alert folks who are on the call, we have pasted in a number of the resources that Sarah has referenced today, including even the link to the Hub Prince Albert. So make sure to take a peek at those resources. Okay. Well, I want to thank you, Sarah, so much for a really exciting and inspiring presentation today to really get us thinking differently about how we can wrap services around those in need to really kind of promote and maintain the health of our population here in Saskatchewan. So with that, we will move to a bit of a wrap-up. So as some may know, we do tend to take breaks, and we will be breaking over the summer months of July and August, but we'll certainly be looking forward to reconnecting with our QI PowerHour community in September. Over the summer, we would encourage and welcome you to catch up on past QI PowerHour sessions by visiting the Health Quality Council website. As always, we look forward to your feedback on today's session, and you can provide your feedback by completing the survey that we will launch when you close out of the WebEx function. With that, I hope everyone has a happy and safe summer. Take care.